Hello, everyone. Welcome to today's live broadcast, the clinical impact and implementation of T2MR and the T2Candida Panel in the management of Candidemia at a large tertiary care health system. I am Kristen Peregentile of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational webinar presented by LabRoots. For more information, please visit labroots.com. This event is sponsored by T2 Biosystems, Inc. T2 Biosystems is focused on developing innovative diagnostic products to improve patient health. With 2 FDA-cleared products targeting sepsis and a range of additional products in development, T2 Biosystems is an emerging leader in the field of in vitro diagnostics. We have a few important announcements before we begin. This webinar is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem through the green Q&A button lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar, please click on the CE button located in the bottom left-hand corner of your web page and follow the process of obtaining your credits. And I would like to now introduce today's speaker, Dr. George Alangaden. Dr. Alangaden received his medical degree from the University of Bombay and has since completed postgraduate training in India, the United Kingdom, and the United States. Dr. Alangaden is the Director of Transplant Infectious Diseases and Director of Infection Control and Prevention at Henry Ford Hospital and Transplant Institute. Dr. Alangaden's research interest lies in the epidemiology and outcomes of infections in immunocompromised patients and transplant recipients. He is also involved and well published in the areas of research related to tuberculosis and nosocomial infections, especially Clostridium difficile. Later, during the Q&A portion of today's webinar, Dr. Alangaden will be joined by his colleagues, Dr. Lanoge Samuel and Dr. Rachel Kenny, who will jointly respond to today's questions. Lanoge Samuel is the Division Head of Clinical Microbiology at Henry Ford Health System. Dr. Samuel completed his fellowship in Clinical Microbiology and Public Health at the University of Rochester in Rochester, New York, and has been serving as the Division Head of Clinical Microbiology at Henry Ford Health System since 2007. Rachel Kenny is a pharmacy specialist in antimicrobial stewardship at Henry Ford Hospital in Detroit, Michigan, where she also serves as Residency Program Director for the Postgraduate Year 2 Infectious Diseases Pharmacy Residency. Rachel received her Doctor of Pharmacy degree from the University of Michigan College of Pharmacy, completed a PGY1 Pharmacy Practice Residency at Detroit Receiving Hospital in Detroit, Michigan, and a PGY2 residency in infectious diseases at Mayo Clinic. Rachel's clinical and research interests include antimicrobial stewardship and antimicrobial medication safety. I will now turn it over to Dr. Alangaden for his presentation.
Hello everyone, welcome. It's my pleasure today to present T2MR implementation and impact on the management of Candidemia at the Henry Ford Health System. The Henry Ford Health System comprises of 4 acute care hospitals and 42 ambulatory centers. Henry Ford is the main hospital based in urban Detroit. It has 800 acute care beds and includes 142 ICU beds and is a tertiary care teaching hospital. The hospital also includes a cancer center and a transplant institute. And the Central Microbiology Laboratory is located at Henry Ford, Maine. So my disclosure statement, I received grant support from Merck, and I'm a consultant to Astellas Pharmaceuticals and T2 Biosystems. My colleagues who will join us during the Q&A session, Dr. Linode Samuel and Rachel Ken. My intent is to help you understand the process for implementation of T2MR and the T2Candida Panel at the Henry Ford Health System, and also understand the impact of T2Candida Panel on the management of patients with candidemia at Henry Ford Health System. As we all know, there are several challenges to the management of candidemia. The clinical features of candidemia are hard to distinguish from those caused by bacteremia. There are no reliable clinical prediction models for the detection of candidemia, even though some models exist for ICU patients and neutropenic patients. These are not consistently reliable. We all realize that blood culture has a sensitivity of 38% to 83% for the detection of candidemia, and moreover, candidemia is associated with crude mortality rates in excess of almost 50%. As a result of the significant mortality associated with delay in diagnosis, this has led to the use of empiric antifungal therapy in what we term as high-risk patients. When we examined our own best practices for the management of suspected candidemia, prior to the implementation of T2MR, we designed it using an algorithm for easy implementation. In a patient who is suspected to have candidemia, which was defined as the persistence of fever or features of sepsis while the patient is on adequate antibiotic therapy for at least 72 hours and has a Candida score. Now, the Candida score of 3 was based on a predictive model that includes variables such as severe sepsis that receives a score of 2, TPN, surgery, multifocal Candida colonization, all of which receive a score of 1. In these patients where you suspect candidemia, our practice is to obtain 2 sets of blood cultures, and at that time we were using 2 serial beta-D-glucan assays of fungitels that were sent to a reference lab for testing. In the meantime, the clinician was permitted to initiate empiric antifungal therapy if the patient had features of severe sepsis. Typically, for an ICU patient, we would have used Anidulafungin, which is a broad-spectrum echinocandin, an antifungal agent that treats almost all species of Candida. If this was a general practice unit patient, where Candida albicans is by far the most common pathogen, then clinicians would often use fluconazole. Subsequently, if the blood culture was positive or the beta-D-glucan assay result was positive and the patient was on antifungal therapy, we would modify the antifungal therapy based on identification of the Candida species and the availability of susceptibility testing. On the other hand, if the blood cultures were negative and the beta-D-glucan assay also was negative, we would prompt the clinician to stop empiric antifungal therapy. Now, once we implemented this and had it running for a couple of years, we realized there were certain challenges with the use of the beta-D-glucan fungitel assay. What we ran into was a high rate of false positive results. Now, the typical normal range of beta-D-glucan ranges from 60 to 80 picograms per ml. We increased this cutoff to a cutoff of 200 picograms per ml based on our hospital data that it was more specific. However, we still had a high false positive rate despite this higher cutoff. The second issue we were running into is the fungitel assay was a send-off test and would on an average take about 4 to 5 days for a result to be available. Furthermore, there was no speciation of the type of Candida species that was isolated from the fungital assay. Hence, we could not modify our initial antifungal therapy. So this led us to looking at new avenues and recent technology, which is the T2MR, and we considered implementing it at the Henry Ford Health System. The rationale for using T2MR was, one, clinical trials had suggested that the T2MR Candida assay has a sensitivity of 91% and a specificity of 99% for the diagnosis of candidemia. Moreover, it had a negative predictive value of 99% for ruling out candidemia. Furthermore, it permitted speciation of the Candida species as it could detect the 5 Candida species that were commonly isolated in clinical practice. So we could modify empiric therapy accordingly. And finally, and most importantly, we could bring the testing in-house so that we could have a rapid turnaround time compared to the fungital assay that was sent out to a reference lab. Now, we anticipated that there would be some impact both clinically on our stewardship program as well as on the lab. The clinical impact that we anticipated was that the rapid detection of candidemia using T2MR and the speciation of the Candida species could result in early initiation of appropriate antifungal therapy. And we thought this might lead to improved patient outcomes, namely mortality. We also anticipated there might be an overall reduction in the length of stay with early identification of infection and possibly an impact on the ICU length of stay. The antimicrobial stewardship impact would result from prompt discontinuation of antifungal therapy and the ability to de-escalate from a broad-spectrum and expensive agent, Anidulafungin, to fluconazole therapy for species of Candida that were susceptible. And this could result in potential cost savings for the pharmacy. On the laboratory, the impact would be primarily discontinuation of the send-out fungital testing, resulting in possible cost savings. This best practice initiative for the management of candidemia was primarily driven by infectious diseases and the pharmacy antimicrobial stewardship program and microbiology. The other stakeholders included leadership from physicians, nursing, and administration. The next few slides, I'll discuss an overview of the implementation of T2MR at Henry Ford Health System. The first and most important step was education that was primarily done by the antimicrobial stewardship pharmacists, the Department of Microbiology, and the Division of Infectious Diseases, and it targeted physicians, nurses, and pharmacists at all of the business units within the Henry Ford Health System. The messaging was provided through electronic newsletters, clinical meetings, and during rounds. And the key messages were, one, when to test and whom to test, proper sample collection, and most importantly, what were the clinical implications of a positive or a negative T2MR test result. In the laboratory, the implementation involved, we implemented the test in November of 2015, and the fungital testing for candidemia was gradually phased out over the next several months. The pharmacy aspect of implementation involved some building of order entries in our electronic medical records. So if a clinician made a request for Anidulafungin, the order set included checkboxes for an ID consultation, for the T2MR order, as well as blood culture orders. When the T2MR results were available in real time, would generate an alert for the antimicrobial stewardship pharmacist in Teradoc, which is a clinical surveillance software system that's used at our center. Some additional details about implementation of testing in the clinical laboratory. The initial step include an assessment of the lab flow with the implementation of T2MR. There were several rounds of validation of the testing done in the laboratory. The testing was done only at the central lab housed at the main hospital in Detroit. T2MR testing was done from 7 a.m. to 10 p.m. Samples received after 10 p.m. were tested the next day, and testing was provided 24/7. We established certain parameters for T2MR testing. We tested patients with suspected candidemia or invasive candidiasis using some of the clinical criteria that I discussed earlier. The recommendations were to draw the T2MR and blood culture always from a peripheral blood draw to avoid detection of colonization of central lines, to draw blood cultures and T2MR simultaneously whenever possible. Now, in event of a negative T2MR result, testing was permitted after 7 days if there was clinical worsening. And we discouraged test of cure for using T2MR. So the new algorithm for the management of suspected candidemia since the implementation of T2MR is similar to the one that I discussed earlier, except Fungitel was removed from our testing and replaced by T2MR. So to quickly walk you through this, patients with suspected candidemia would get 2 sets of blood cultures and a peripheral blood draw for T2MR. The clinician could initiate the patient on empiric antifungal therapy if severe sepsis, and subsequently, if a blood culture or a T2MR assay result was positive, the antifungal therapy, if it had been started, could be modified quickly based on the species identification on T2MR and subsequent susceptibility testing from blood cultures when available. On the other hand, if blood cultures and T2MR assays were negative, we recommended stopping empiric antifungal therapy. In addition, patients who had a positive blood culture or a T2MR assay, an ID consultation was recommended. An ophthalmological eye exam was requested 5 to 7 days after detection of candidemia to identify any eye involvement from the candidemia, namely retinitis or vitritis. Clinicians were encouraged to remove IV lines if that was suspected to be the source of the candidemia, and repeat blood cultures were obtained after starting therapy to document clearance of candidemia. What I've shown here is an example, is a screenshot of an Anidulafungin order panel that was built into our order set in the electronic medical records. As you can see above is the order for Anidulafungin, and included in this order set was a T2MR order that was built in so that the clinicians could check this off at the time of requesting Anidulafungin. And as Rachel will emphasize to you later, this was an important step in our algorithm to ensure compliance. So at this time, I've given you an overview and some details about the implementation of the T2MR system and the T2Candida Panel at Henry Ford Health System. And during the Q&A session, we'll have an opportunity to talk in more depth with Rachel and Linoj about challenges and process improvements to this process. The second half of my presentation will discuss the impact on the management of candidemia and our early experience. This work was done primarily by the pharmacy under the direction of Rachel Kenny. So this study examined the impact of T2MR implementation and the use of T2Candida Panel and the improvement in the timely management of candidemia. The study design was a single pre-test, post-test quasi-experiment. The study population included all patients at Henry Ford Health System that were diagnosed with candidemia from April 2015 until May 2016 using either blood cultures, beta-D-glucan, or T2MR. The data abstraction was done from electronic medical records using a standardized case reporting form that included patient demographics, risk factors for candidemia, diagnostic information, the treatment and management, and outcomes. Standard statistical analysis were used to characterize the patient population as well as the other outcome results. The primary endpoints of the study was 1, time to appropriate antifungal therapy that was defined as the time of lab order for the diagnostic test until the time to initiation of antifungal therapy. The second primary endpoint was time to detection of candidemia, defined as the time of the lab order to the time of the first actionable result. The secondary endpoints included overall length of stay and ICU length of stay after the onset of candidemia. It also included complications of candidemia causing retinitis or vitritis in the eye, and all-cause crude in-hospital mortality. We did not assess mortality attributable to candidemia. Shown here are the results. When we examine the time endpoints in the pre-T2MR period and the post-T2MR period, we can see that the time to appropriate antifungal therapy was significantly shorter in the post-T2MR period, from almost 40 hours in the Fungitel period to 26 hours and 27 hours in the post-T2MR period. And this was statistically significant. Examining time to detection of Candida species, this also was significantly impacted by T2MR, and it decreased from approximately 42 hours in the pre-T2MR period to 25 hours in the post-T2MR implementation period. Now, the additional things that I wanted to discuss in the time to detection of Candida species in the post-T2MR period, when we examine the turnaround time in only the T2MR group, excluding blood cultures, the turnaround time was even shorter. It was 7 hours, and this could impact clinical management, length of stay, and other variables. So the total length of stay was not statistically significant. However, it had decreased from 13 hours to 9 hours. More importantly, the ICU length of stay declined from 13 hours to 6 hours, and this was strongly significant. It is unclear at this time the association of this reduction in ICU length of stay and T2MR, and we are examining additional variables that could have affected this positive impact. We also examined ocular candidal involvement, and this decreased from 30% in the pre-T2MR period to 8% in the post-T2MR period. Our hypothesis is that possibly earlier detection by T2MR at a low level of detection resulted in prompt therapy, and this needs further investigation. As you can see, there was no significant impact on mortality. Now, mortality, as you realize, is a hard endpoint, as these ICU patients have greater severity of illness, and larger studies would be needed to explore this as an endpoint. In addition to the previous study, we also examined the impact of a negative T2MR result on antifungal stewardship. There were 155 patients who were identified with a negative T2MR result. Antifungals were given to 49 of these 155 patients, while the T2MR result was pending. As you can see, there was a positive impact on antifungal stewardship. The average days on antifungal therapy in those 49 patients was 1 day, with a range of 1 to 3 days. The clinical response to a negative T2MR result, 71% of patients, the empiric antifungal therapy was discontinued on receiving a negative T2MR result. In another 4%, we were able to de-escalate Anidulafungin to fluconazole based on the Candida species identification provided by T2MR. However, a quarter of the patients, the therapy, there was no change, and this certainly needs to be examined further. Now, we also learned some important lessons along the way. We realized a large proportion of our patients who had candidemia detected by either blood culture or T2MR did not fit the traditional profile as shown by the Candida scoring system that we used. So it was important for us to maintain a high index of suspicion for candidemia in patients with sepsis, even though they may not have met a Candida score of greater than or equal to 3. We also saw discordant results between T2 and MR that emphasizes it's important to draw paired samples, to draw samples before administration of antifungal therapy, to always do peripheral blood draws to avoid colonization that might exist in central lines, and proper skin cleansing, because being a very sensitive PCR test, this might lead to contamination during collection of blood samples. We also realized it's critical to do continuous quality monitoring of the test performance in the laboratory. And furthermore, we needed to re-emphasize discontinuation of antifungals if blood cultures and T2MR results were negative. And some of these performance quality measures, we'll have a chance to discuss them during our Q&A session. Now, the limitations of the study include this is a single center experience. This is very early experience. It's a new novel test, and there's always a learning curve. The interpretation of a positive T2MR in the absence of a positive blood culture is still challenging. There was non-uniformity of blood collection in the real-life setting that could have impacted this. And blood culture, which is considered the gold standard, itself may be too insensitive to kind of give us the true meaning of a positive T2MR test. So, in summary, our early experience after implementation of T2MR and the T2Candida panel at the Henry Ford Health System appears very promising. T2MR implementation was associated with significant reduction in time to detection of candidemia. It improved significantly time to initiation of antifungal therapy. Unnecessary antifungals were rapidly discontinued in almost 3/4 of the patients. It resulted in reduced ICU length of stay. There were fewer patients who had involvement of the eye resulting from candidemia. However, there was no significant difference in mortality. Some of our early experience was presented at ID Week, and I've shown you here the abstracts that were presented that I had discussed in this presentation. Thank you all for your attention. It was a pleasure to discuss our experience with you.
Thank you for that informative presentation, Dr. Alangaden. Before we get started on the question and answer session, I would like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. I will now turn it over to Drs. Alangaden, Samuel, and Kenny to take questions.
Hello, everyone. At this time, I would like to invite our co-panelists, Drs. Rachel, Kenny, and Samuel, to join the discussion. And I will start with Rachel. So Rachel, when you look back at our experience, how cost-effective is this test in our experience?
I can speak a little bit to the pharmacy return on investment in avoided antifungal use, although we haven't done a formal economic analysis. Our antimicrobial stewardship program did conduct an internal medication use evaluation of 70 patients to determine the downstream impact of a negative T2MR on antifungal therapy. And when we compare to our own historical data, we estimate that the T2MR allows us to rule out candidemia in approximately 140 patients per year. And compared to our old standard of care, that translated to an avoidance of approximately 6 Anidulafungin maintenance doses for each of those 140 patients. So when you assume an average wholesale price of about $180 per Anidulafungin dose, that could translate into as much as $150,000 per year in avoided echinocandin costs.
So, as many of you all realize, the implementation of a new test in a large healthcare system presents challenges. So Rachel, what were challenges to the implementation of T2MR from a pharmacy and antimicrobial stewardship standpoint?
I think for us, given the size of our institution, implementing effective education is always a challenge. We knew that we needed to educate nurses, pharmacists, prescribers, our microbiology staff, and we knew that we wanted to emphasize a few key educational messages, including when the test would be clinically indicated, how to properly collect the test specimen, and the clinical implications and how to respond to those positive and negative tests.
Great. What do you think should be the key messages from the pharmacy and the antimicrobial stewardship standpoint for any institution considering implementation of T2MR?
So as I mentioned, education was one of our biggest challenges and also absolutely essential. But we recognized that in addition to a couple of rounds of education, we needed some strategies that would be a little more sustained. I think one of the most important strategies we used was the creation of the order panel in the electronic health record, and that helps maximize our adherence to the guidelines so that we can accomplish both prompt empiric antifungal therapy and obtain the most appropriate diagnostic tests in a timely fashion. But even with a guideline, all of our education, the best practice hardwired into our electronic health record, I would say that our time to antifungal therapy is still not where we want it to be. So measuring and continuing to refine and look for new ways to improve is also another key step to success. So subsequently, we've worked with our electronic health record programmers to ensure that our echinocandin loading doses always default to stat. And our microbiology lab, as kind of a second phase of our rollout, is now calling positive T2 results as a critical value, just like they would with any other blood culture.
That was very informative, Rachel. If I can now turn to Dr. Samuel Linoj, as the director of the microbiology lab, what were the laboratory challenges with implementation of the T2MR test?
So, a couple of challenges we faced was this is a novel assay, and to leverage the maximum efficacy of the testing platform, we had to run this at least across 2 shifts to provide timely results. And although it is a cartridge-based assay, we felt we needed to treat this like a traditional molecular assay. So we had non-molecular trained techs running this assay, and we went through several rounds of training by the company staff over the course of the first couple of months. And we felt this was absolutely essential to avoiding contamination issues that might occur during the testing process, and that did on occasion occur. So it is absolutely important that techs are trained well and that there's monitoring of the positive results that are coming off the machine to look for unusual patterns in test results, and to ensure that staff are following appropriate protocols as needed. We also took some additional steps to reduce the risk of contamination, such as use of a dead air box to prepare specimens, and also using disposable materials and pads for each specimen separately when we were setting them up. As Rachel mentioned, we didn't start off treating this as a critical value, but we did transition to treating this as a critical value, and so these results are called as they come off the machine. And we also looked at we looked at our rate of invalids, and we did not see the high level of invalid results that were seen in the clinical trial. So that was something that initially been an area of concern for us, but we did not have that happen.
Great. Linoj, now we all realize that T2MR is not an inexpensive test. So how would you address the cost justification of the test in the clinical laboratory?
Mm-hmm. So this was a bit challenging. This is where we had to partner with our ID and pharmacy colleagues. We did see some cost savings because we had significant volumes of fungal antigen testing being sent out, and that gave us some significant savings. But that alone is not enough to offset the cost of the assay, and so I think that's where the laboratory needs to look to their clinical colleagues to show cost savings from a patient care perspective and a microbial usage perspective, et cetera, to cost justify the instruments.
And finally, often it's important to have a multidisciplinary team to successfully implement any change. So how did the lab partner with clinical colleagues to effectively implement the T2MR test?
Mm-hmm. Yeah, so again, this was a collaborative relationship with ID and pharmacy, and given the expense of running the test, we really want to ensure appropriate test utilization, and we worked with them to set up the criteria for frequency of testing, the criteria for selecting patients for testing, And then once a patient was positive, how frequently would you repeat? And I think those are all institution-specific decisions that need to be made locally because there are no guidelines to support you. So those are things we worked with them. We also reached out to nursing councils, and we did a lot of education through nursing councils to reach us. This was a novel test and not something that they were used to ordering. And I think part of the issues with avoiding contamination is ensuring that specimens are collected appropriately. We recommended that they avoid lines, for example, and the instrument really requires the correct amount of sample to be drawn, the volume of sample to be drawn in the tube as well. And so those are issues that will reduce the number of invalid or rejected samples as well.
Great. Thank you, Rachel. Thank you, Linoj.
Thank you. I would like to once again thank Dr. Alangaden for his presentation. Do you have any final comments for us?
So I would say over the course of this presentation and the Q&A session, I hope we have given you an understanding of the successful implementation of T2MR and the T2Candida panel at Henry Ford Health System, and I've also provided an understanding of the positive impact the T2Candida panel had on the management of patients with candidemia at Henry Ford Hospital. So thank you all.
Wonderful. Thank you. Today's webinar will be available for on-demand viewing through November of 2017. You will receive an email from LabRoots alerting you when it will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. We'll see you next time. Goodbye.